Hey guys, welcome to Unacademy. Welcome to Let's Crack NEET PG. So today's session, okay, and there's a small difference you might have noticed. I have got a green screen right here behind me. So today's session, as you all might know, is on Ganong's clinical box series, right? So this is a session I run since Ganong is your standard. Sorry, excuse me. I've opened my phone so that I can access the live chat from you guys. So yeah, coming back to what I was saying, this session is based on Ganong's clinical boxes, right? And as you all know, for physiology, the standard textbook, it happens to be Ganong, right? If someone asks ki reference kahan ka doge while answering, so it happens to be Ganong, okay? And if you're having any problems with the video, please let me know. It's the first day I'm using this green screen, so please let me know if there's any issue with that, okay? So the topic that we are going to be discussing is called as idiopathic pulmonary fibrosis. Okay, so now why we are discussing this? Because this disease is said to be a prototype. This disease is said to be a prototype of restrictive lung disorders. Okay, so our goal in physiology is to understand the restrictive lung disorders, right? Everything else is secondary. Okay, everything else I teach you today will be related to the pathology of the actual disease, right? But through this disease you have to understand what are restrictive lung disorders, right? What are restrictive lung disorders? So before I begin, my name is Chetanya Mittal. I'm currently pursuing my MBBS at AIIMS New Delhi. So I hope you all have downloaded the Unacademy learning app. You guys can use my referral code Chetanya10 to unlock the free plan on the app after you register with your mobile number, okay? So that you can access all the content on Unacademy that is free of cost, okay? So these are some of the top educators. They're teaching live on Unacademy. You can see they're making plus courses which are paid, as well as at the same time they're making special classes which are absolutely free of cost. So to take advantage, you can use my referral code and unlock the free plan. Unacademy is currently a one-stop solution for your NEET PG preparation needs. We are offering the live classroom experience with batch courses, special tests and weekly tests, and we are also having a doubt clearing feature under Ask a Doubt. Okay, we've started batches from tomorrow for NEET PG, INI CET, FMG and next. Okay, so all batches are running. They will be starting tomorrow, and we have an MCQ question bank that has over 34,000 plus questions, right? So your practice will never end, okay? And these are some of the latest batches. You can access all this information on the app. I won't bore you here with all that. Okay, I'll quickly tell you about the two subscriptions. One is the Unacademy Plus subscription, where you are getting all the benefits that are there on the Unacademy platform, and one is the subscription called as the iconic subscription, where you are not only getting the benefits of Unacademy, but you will also be getting access to Prep Ladder, right? You will also get a login detail for Prep Ladder. So that is the difference between the two. And Prep Ladder, as you all know, we have premium recorded video lectures. Question Bank 3.0 is coming up in 2021, as well as you will get the handwritten notes. Okay, so if you look at the pricing, we have a very exciting offer going on for the iconic subscription plan. Okay, all you have to do is use my referral code Chetanya10 and you will get a discount of 35,000 rupees, right? 35,000 rupees on the 3-year plan. It was earlier for 92,000, you will get it for 58,500, right? 2-year plan you will get for 50,000 and the 1-year plan you will get for 40,000. So it's a really great offer that's going on right now, and you guys can take maximum advantage of it. Okay, for the plus subscription, you can take the 1-year plan. It's for 25,000, and the 2-year plan it's for 36,000. And here you will get an offer that is, if you want to try Unacademy Plus, you can take it for 3 months and you will get a 1-month free extension on it. Okay, that is something you can do. So let's start with Ganong's clinical box series on idiopathic pulmonary fibrosis. So I hope you have watched yesterday's class. Yesterday we had a session on asthma. And yesterday I told you certain basic things. Right? So this is the series. Hi Anurag, I am doing great. How are you? Okay. And the clinical box is clinical box number 34.2. The topic is altered airflow in disease, right? Altered airflow in disease. So yesterday I told you about this particular graph, right? This was the graph that was there. That is the spirometry clinical test that is done for lung diseases, right? This test is done where the subject is asked to take a maximal inspiration and then forcefully expire all that air, okay? And the volume of air that is expired, it's called as the forced vital capacity. It's called as the forced vital capacity, and the volume of the forced vital capacity that's expired in 1 second is called as forced expiratory volume 1, FEV1, right? And the ratio of, so I told you yesterday certain things, the ratio of FE1 V1 by FVC, okay, it should lie between 0.7 to 0.8. If it is less than 0.7, it is a obstructive disorder, okay? And as you will see, in obstructive disorder, mostly you will have problem in expiration. You will have mostly problem in expiration. Understood? So the reason for that is, in obstructive disorder, there is an obstruction to expiratory flow. Now, if this obstruction, it improves when you give the patient bronchodilators, right? If it improves, that is, it is reversible. It is reversible. Okay, I'm talking in a very broad way right now. If it improves when the patient is given bronchodilators, okay, it again becomes greater than 0.7, then most likely this is reversible, so it is called as asthma. It is called as asthma, right? Partly reversible. And if it does not show improvement, if it does not show improvement, okay, there are certain cutoffs for this, ठीक है, कि कितने पे improvement कहते हैं और कितने पे improvement नहीं कहते हैं, then it is called as COPD, right? Now COPD, it includes two conditions, okay? COPD, it includes two conditions. It includes emphysema, right? And it includes chronic bronchitis. It includes chronic bronchitis, right? Besides that, you have bronchiectasis. Bronchiectasis, you might have heard of bronchiectasis or small airway disease, right? So all of these disorders, okay, I hope you can read now. So all of these disorders, they are examples of obstructive lung disorders, right? Now let's come to talk about, so obstructive disease, the characteristic is that there is a decrease in the forced vital capacity as well as there is a decrease in the ratio of FEV1 by FVC. That is characteristic of obstructive disease, okay? Now what about restrictive disease? What is the meaning of restrictive disease? Okay, so let's understand what is restrictive lung disease, okay? So here also you are having abnormal lung function. You are having abnormal lung function, but the main problem is not a problem with expiration or an obstruction, okay? The main problem is that the volume of your lung has got restricted, right? So there is a decrease in the total lung capacity, okay? All the capacities and the volumes that you are studying about, they are going to decrease. They are also going to decrease. Understand this first thing. Total lung capacity, it is decreased. Vital capacity is decreased. Functional residual capacity is decreased. Residual volume is decreased, right? But that is in the severe case of the condition, okay? There might be certain variations. So now if we are talking about the ratio FE1 V1 by FVC in this particular scenario, you have to understand that there is a decrease in FEV1 also and there is a decrease in FVC also, right? Now because both decrease either equally or the decrease in FVC is more than the decrease in FEV1, okay, what happens to the overall ratio? The overall ratio, it either remains same or it may be slightly increased. Remains same, or I'll just write normal, okay? So it continues to lie between 0.7 to 0.8. It continues to lie between 0.7 to 0.8. I hope you can see 0.7 to 0.8. That is the range in which it lies. Okay? समझ गए? 0.7 to 0.8. Okay? So are you guys liking this new camera setup? Is it better to learn this way? Do you feel that this improves your learning? I want some feedback from you guys कि इससे थोड़ा better लगता है क्या? ज़्यादा professional लगता है क्या? Okay, ठीक है. बाकी I'll continue what I was telling you. So there can be two classifications of restrictive lung disease. Okay, how can you further classify restrictive lung disease? how can you further classify restrictive lung disease? Okay, so you can classify it into two kinds. Okay, some restrictive lung diseases, they have a pulmonary component, while others, they also have, simultaneously they also have an extra pulmonary component. For example, restrictive lung diseases, they can be associated with autoimmune disorders. For example, 30 to 40% of the times in rheumatoid arthritis, you have lung involvement, right? You have lung involvement. Then there is one more disorder, systematic lupus erythematosus, right? That is also an autoimmune disorder. Okay, what else do you have? You have a disorder called as scleroderma, right? In that you have a correlation. Then there is one disorder called as dermatositis polymyositis, right? That is also an autoimmune disease. So just remember rheumatoid arthritis for right now. Okay, now why is rheumatoid arthritis important? I'll tell you. There is a group of conditions known as Kaplan syndrome. There is a group of conditions known as Kaplan syndrome. Basically, it's a disease. Okay, Kaplan syndrome is basically rheumatoid arthritis when it is accompanied by poll workers pneumonocosis, right? When it is accompanied by pneumonocosis, I'll tell you what is pneumonocosis, right? That is called as Kaplan's disease. Okay, it is different from pneumonia. Please don't get confused between pneumonia and pneumocosis, right? So please don't get confused between these two conditions. Okay, understood? Okay. So what had we studied about asthma? Asthma was a chronic airway inflammation which was reversible with expiratory airflow obstruction, usually seen in early morning or late night. We learned about acute severe asthma, also called as status asthmaticus. We had studied the classification of asthma into atopic and non-atopic. We had understood the mechanism of atopic asthma pathogenesis. It's a type 1 hypersensitivity reaction mediated by Th2, that is type 2 helper cells, and there was the role of interleukin 4, 5 and 13, right? So we had seen all the mediators, leukotrienes, acetylcholine, interleukin 5, galactin 10. Okay, so we had studied all this, right? We had also seen the genetics, what is chromosomal association in this particular disorder, what are the non-atopic asthma, what are the causes, right? What is drug-induced asthma? Why does aspirin cause drug-induced asthma? If you guys remember, why does aspirin cause drug-induced asthma? It's a very important point to understand. Okay, so I'll just quickly repeat it. Why does aspirin cause drug-induced asthma? Aspirin is a non-steroidal anti-inflammatory drug, right? So what happens? You have in your body a metabolite called as arachidonic acid. Arachidonic acid. So for simplicity, you can understand that it can either be metabolized by the COX pathway, that okay, COX stands for cyclic oxygenase, or it can be metabolized by LOX, right? That is lipoxygenase. So cyclic oxygenase will convert this broadly to prostaglandins, right? Prostaglandins, and LOX pathway will convert it. Let's say it also forms lipoxins, but I am writing mainly leukotrienes. Okay, leukotrienes, LTs. Okay, I am writing LT. So I hope you can make out on your own what is the meaning of LT, right? Leukotrienes. Now leukotrienes, as you all know, I have just told you leukotrienes C4, D4, E4, these are all involved in the pathology of asthma because they are bronchoconstrictors. So NSAIDs, what they do is they inhibit the COX pathway. They do not allow this pathway to function. So all the arachidonic acid, it gets converted to leukotrienes. So there is an overproduction of leukotrienes in some people who are sensitive to aspirin. In some people who are sensitive to aspirin. Okay? So that is how. It's an oversimplification what I'm explaining to you, but it works. Okay? Occupational asthma. Then there's occupational asthma, and I've told you about the hygiene hypothesis also, right? So now let's talk about today's topic, that is idiopathic pulmonary fibrosis. Let's come to idiopathic pulmonary fibrosis. So what can you make out from the words? What can you make out from the words idiopathic pulmonary fibrosis? Can you give me certain what do you yourself understand from the words idiopathic pulmonary fibrosis, right? So if you yourself tell me idiopathic pulmonary fibrosis, you can make out first of all idiopathic. It means that the cause is unknown. Cause is broadly unknown. Okay, that is the meaning of the word idiopathic. Pulmonary obviously means it affects the lung, and fibrosis means that there will be deposition of collagen, there will be formation of fibroblastic centers. Okay, so we'll also discuss that why that happens. Okay, so we are not very clear of the etiology and the pathogenesis, but whatever we know, I will describe to you. Okay. So first try and understand that restrictive diseases, they can be further classified into infiltrative lung disorders and disorders that affect the chest wall. Disorders that affect the chest wall. Okay. So what do I mean by that? Okay, what do I mean by that? When I say that a certain disease is infiltrative, when I say that a certain disease is infiltrative, it means that it is directly going to affect the lungs. Okay, there is going to be formation of fibers, that is basically your deposition of collagen, right, or any other kinds of fibers in your lungs, lung alveoli, or interstitium of the lung, right, either in the lung alveoli or in the lung interstitium, right. So it can either be intra-alveolar or it can either be interstitial. It can either be interstitial, right. Now that is about an infiltrative kind of pathology. Okay, now the other kind of diseases, restrictive diseases, they can be related to the chest wall. Okay, so I'll give you a few examples. For example, do you understand what is kyphosis or kyphoscoliosis, right? So in that, what happens, there is a basically a bending of your spine. Okay, there are three terms: kyphosis, scoliosis, and lordosis. Do you understand the differentiation between these three? Kyphosis, scoliosis, and lordosis. Okay, so if you are getting curved forward, what is going to happen? If there is going to be a forward bending of your upper part, that is kyphosis. Okay, if your tummy is coming out, that is lordosis. That is, there is a hypercurvature from behind it. Okay, that is called as lordosis. And if you are bent towards the side like this, right, if your chest is tilted towards one side, or your vertebrae is tilted towards one side, that is scoliosis. So in that, what happens, your chest wall, because you are having an abnormal curvature, your chest wall gets smaller, and because of that chest wall anomaly, you are going to have restrictive lung disorder. You are going to have restrictive lung disorder because of a chest wall anomaly, right? So that is about kyphoscoliosis. Similarly, you have polio, right? Polio, there is going to be certain kind of a paralysis, and because of that paralysis, your external intercostal muscles, internal intercostal muscles, your diaphragm, all of those, they are not able to contract properly, and again you have a restriction in your breathing. So in restrictive lung disorders, you will have a lot of problem with inspiration also. Obstructive lung disorders, the main problem was expiration, right, because expiratory, you were having certain expiratory airflow problems. But here the main problem might lie in the fact that you are not able to take in enough amount of air, right? So that is again a cause of disease here. Okay. So now let's go into the details of idiopathic pulmonary fibrosis. What is the definition of idiopathic pulmonary fibrosis? Because we just said that the cause is unknown. ठीक है, जब हमें पता ही नहीं है कैसे हुआ है, तो हमने ये कैसे बोला कि क्या हुआ है, right? So it is characterized by progressive interstitial, please note the word interstitial pulmonary fibrosis, accompanied by respiratory failure. That's the first thing that you guys will write about this particular, write मतलब अपने मन में, that's the first thing that you will keep in mind when we are talking about this particular condition. ठीक है, so is everything clear up till now? I just want to take a feedback from you guys, that have you guys understood everything that we have done so far? Everything that we have done so far, is that much clear to you? Any doubts in that part? Hopefully not. So let's move ahead. So it is also called as usual interstitial pneumonia. Okay, now I am telling you another word for idiopathic pulmonary fibrosis. It's also called as usual interstitial pneumonia. Why I am specifying this? Because there is also another kind of, so this is written as UIP. It is written as UIP. There is another pattern of inflammation that is called as NSIP. That is called as non-specific interstitial pneumonia. That's called as non-specific interstitial pneumonia. Right? And there is another word for it that is called as This is basically not used too much in the US literature. Okay, this is used in Europe. This is used mainly in Europe. It is called as cryptogenic fibrosing alveolitis. Okay, this is not important for you. This word is not important for you. This is the one that is important for you. Okay, so idiopathic pulmonary fibrosis is also called as usual interstitial pneumonia. Right now, your Ganong, it is writing a few lines, and these are the lines I want to explain to you. Okay, Ganong में ये सब लिखा हुआ है. Okay, so your basic cause of this disease, basic cause of this disorder is that there is alveolar epithelial injury. Okay, there is an injury to the alveolar epithelium. Now, why does that injury happen? Why does that injury happen? Okay, so there are three main causes. There are three main causes that I'll explain in detail. Don't worry. Okay, abhi I'm just summarizing. First, there is certain problem with apoptosis. There is certain problem with apoptosis. Second problem is that due to accumulation of certain misfolded proteins, there is a stress on the endoplasmic reticulum. You might have heard of ER stress response. ठीक है, देखो बेसिकली अगर सेल में बकचोद से गंदे से प्रोटीन बनने लग जाए तो सेल जो होता है वो कहता है कि भैया ये तो बहुत स्ट्रेसफुल हो रहा है मेरे लिए, मेरे से अपने खुद के प्रोटीन ही नहीं बन पा रहे हैं, तो उसको एक क्राइसिस हो जाता है, सेल को खुद ही एक क्राइसिस हो जाता है, उसे कुछ समझ नहीं आता मैं क्या करूं, तो सेल मरने लगता है. देयर इज एन इंजरी टू द सेल. And the third thing is epithelial to mesenchymal transition. Because of certain cellular stresses, the cells which are epithelial in nature, they start getting converted to mesenchymal. Okay, this is also important in embryology, but here it has a pathological role. Epithelial to mesenchymal transition, this is written as EMT. Okay, so these three words, they are specifically mentioned in your Ganong. They are specifically mentioned in your Ganong. Okay, understood this? Should I move ahead? डिड यू अंडरस्टैंड? बिकॉज अभी इसके बाद मैं इन्हीं चीज़ों को थोड़ा डिटेल में एक्सप्लेन करूंगा. आई एम गोइंग टू एक्सप्लेन दिस इन डिटेल. सो इफ यू गाइज हैव एनी डाउट्स यू कैन राइट एटलीस्ट येस और नो इन द चैट बॉक्स. You guys have any doubts, you guys can let me know. Yes, no कर दो. And if you have understood everything, please remember to hit the like button. Please remember to hit the like button. No doubts? Any doubts? Guys, yes, no? Because after this what we are going to be doing is going to be slightly more difficult now, so I want ki at least yahan tak your doubts are clear. That's the only advantage of having this in the form of a live class, right? Otherwise it could be simply a recorded session. Okay, so the advantage is that you guys will be able to remember. Okay, Okay, no doubts, no doubts, right? Okay. So we can move ahead. Okay. So the cause of idiopathic pulmonary fibrosis, it is said that the cause is unknown. ठीक है, ये तो आपने ऑलरेडी नाम पढ़ के आप प्रिडिक्ट कर दिया था, राइट? यू हैड ऑलरेडी प्रिडिक्टेड बाय रीडिंग द नेम. ठीक है, सो दैट इज व्हाट दिस इज, दैट इज बेसिकली what this is going to be, right? So now there are certain risk factors. ठीक है, we say that the exact cause is unknown, the exact cause is unknown, but it does not mean that we don't understand anything about the disease. Okay, that does not mean we don't understand anything about the disease. Okay, so we do understand a few things, we do understand a few things, right? And those few things we are going to understand, we are going to understand. ठीक है, so let's start with that. So what are the risk factors? What are the various risk factors that are going to be there? What are the various risk factors that are going to be there for this disease, right? So cigarette smoking is a risk factor for almost every disorder that you see, right? It's a for almost every pulmonary disorder, cigarette smoking is a risk factor. Besides that, there are certain things in the air like air pollution, farming as a profession, hair as a hairdresser, as a stone polisher. You are exposed to certain chemicals which make you more likely, right? Which make you more likely to getting exposed. Okay. Now the third important thing that I'm going to tell you, remember we just said that there is one very important thing that gets misregulated, that is apoptosis, that is apoptosis. And why that happens at a lot of times, that in the alveolar epithelial cells, in the alveolar epithelial cells, that is the type 1 and type 2 pneumocytes, it is commonly seen that there is a phenomena that happens that is called as telomere shortening, the telomere shortening. If you remember why cancer cells are immortal, so one of the reasons is that their telomerases are very effective, so they can keep the length of their telomere intact. But if the telomere gets shortened too much, it means that the cell has undergone a significant amount of damage. So you will commonly see mutations in genes called as TERT, right? Telomerase reverse transcriptase. This stands for TERT, right? Telomerase reverse transcriptase. Then there is a gene called as TERC. So you can again see the word telomere is there. Okay. Then there is a gene called as PAN, and there is a gene called as RTEL1. Reliance Airtel 1. ठीक है, ठीक है, छोड़ो जीन्स का नाम इंपॉर्टेंट नहीं है, you can just remember this one gene. Okay, telomerase reverse transcriptase. So there is a defect in the telomeres, so there is some defect involved with the telomeres. So these genes, these 4 genes, they are responsible for maintaining the length of the telomere, right? And if there is a mutation in these genes, the telomere, they get shortened, and because of that the cell feels, अरे मैं तो damaged हो गया, तो cell क्या करता है, apoptosis कर लेता है, and because of that you have the cells start to get replaced by fibers. So that is leading to fibrosis, that is going to lead to fibrosis. So that is one thing. Second, what we saw was that there is a gene called as MUC5B, MUC5B, right? And this MUC5B gene, it is leading to the production of a protein called as MUC5. Okay, now this is basically mucin, this is one of the members of the mucin family. So now if there is excessive mucin, what happens, that mucin, it has to be cleared ideally by your cilia, right? Mucociliary clearance. But because there is so much mucin, because there is abnormal amount of mucin, that mucin will accumulate and that will cause damage to the alveolar epithelial cells. Exact things, they are not very much known here. Okay. Third thing, that this disease is generally seen only in people who are above 50 years of age. So age is again a risk factor for this particular disease. Age is again a risk factor for this particular disease, right? Another mutation that we have seen is a mutation in the surfactant protein. Another mutation that we have seen is a mutation in the surfactant protein. So as you know, surfactant, it has phospholipid, that is lecithin, and it has surfactant proteins like surfactant protein A, B, C, D. Okay, so there is certain misfolding in them, there is certain misfolding in them, and because of this misfolding, it activates the ER stress response. Okay, endoplasmic reticulum stress response, right? And again, that is involved in the pathogenesis of the disease. So we have discussed ER stress response, we have discussed apoptosis, and there was one more thing that was happening, that was EMT, that was EMT. And finally, there is so we have seen so far that there is going to be alveolar epithelial injury, right? We have said that the alveolar epithelium, it gets injured, right? Now you might ask कि चलो ठीक है इंजरी तो होगी, but fibrosis कौन करा रहा है? Who is causing the fibrosis? We still haven't understood why fibrosis is happening, right? So it is said, it is hypothesized that there is a mediator TGF beta, ठीक है, transforming growth factor beta, and as you know, it has a very powerful potential for fibrosis. So it is said that alveolar epithelial injury, it leads to the release of TGF beta, which is connecting the alveolar epithelial injury to the fibrosis that is happening, right? So the clinical picture, where all will you have fibrosis? You will have fibrosis in the lower lobes, you will have fibrosis in the subpleural regions and in the interlobular septa. Okay, so you have to remember कि lower lobes में it is happening predominantly. It is happening predominantly in the lower lobes. ठीक है? One more thing that is happening in the lower lobes is asbestosis. ठीक है? It is also a restrictive lung disorder, and how you can remember it is that it has the word base in it, right? Asbestosis. So base refers to lower lobes. Base refers to lower lobes. Okay, that's a small mnemonic that you guys can use. Okay. Now the hallmark of the disease. The hallmark of the disease is patchy interstitial fibrosis, and it ultimately progresses to what is called as honeycomb fibrosis. So wherever you see this option, honeycomb fibrosis or patchy interstitial fibrosis, you always have to think of idiopathic pulmonary fibrosis. This is for your MCQ point of view. This is from a MCQ point of view, right? Now what is the treatment? What is the treatment? Now why I'm telling you the treatment, because or the pharmacology, because your Ganong, even though it is a physiology textbook, it also gives you some correlates of pharmacology. ठीक है, उसके नीचे दिया होता है कि how do you treat that disorder, what are the various treatment modalities. Okay, so no specific medication is there, but we are using two drugs. ठीक है, no need to go to the names of the drugs, but they are written in your Ganong, so I am just telling you. Okay, NIN TED NIB. Okay, so how I read this is 9 tedha nib, 9 tedha nib, right? So that is what you can remember, whatever way you want to read it, nin tedha nib, or whatever way you want to read it, 9 tedha nib. Okay, so the important thing is that it is a tyrosine kinase receptor blocker. It is a tyrosine kinase receptor blocker. And what is the importance of tyrosine kinase in this disease? Tyrosine kinase is, for example, TGF beta, when it has to perform its signaling, so it uses the tyrosine kinase receptor signaling. So it blocks this signaling, and thus it slows down the fibrosis, that is causing problems in the disease, right? So that is one way of action for the disease. So the fibrogenic factors like platelet derived growth factor, vascular endothelial growth factor, fibroblast growth factor, all of these, they are going to work through tyrosine kinase receptors. So to block that, we use a tyrosine kinase receptor blocker. Okay, that is one thing that we do. Okay, got it? So there are certain other drugs. Certain other drugs that we can use. So there is a drug called as pirfenidone. It is written in your Ganong again. Pirfenidone, right? And what it does is it reduces fibrosis. It is an anti-fibrotic agent that inhibits TGF beta. This specifically, it inhibits TGF beta. So it is again an anti-fibrotic agent. It's an anti-fibrotic agent. The names of the drugs, it's okay if you guys don't remember them right now. It's absolutely okay. You are not required to remember these drugs. Okay. And last thing that you have to understand is that the most common interstitial lung disease for which lung transplant is performed is interstitial pulmonary fibrosis. The ultimate treatment of interstitial pulmonary fibrosis, is lung transplant. And what you can remember is that it is the most common It is the most common interstitial lung disease for which lung transplant is performed. And it is the second most frequent disease for which lung transplant is performed. Okay? It is the second most frequent disease for which lung transplant is performed. Got it? So now your homework. Which disease is the disease for which lung transplant is most commonly performed? Okay, so what I have told you, that idiopathic pulmonary fibrosis is the second most common disease, right? So now you have to tell me which is the most common disease for which lung transplant is performed. Can you tell me right now? Anyone knows the answer? मोस्ट कॉमन डिजीज फॉर विच लंग ट्रांसप्लांट इज परफॉर्म, मोस्ट कॉमनली ऐसी कौन सी डिजीज है जिसमें लंग ट्रांसप्लांट करते हैं? एनीवन? एनीवन कैन टेल मी? साइंस एंड सिम्टम्स आई होप यू कैन मेक आउट. डिस्निया होगा, कफ होगा, साइनोसिस हो सकता है. अल्टीमेटली इट लीड्स टू पल्मोनरी हाइपरटेंशन, राइट हार्ट फेलियर, राइट, कोर पल्मोनरी, ऑल ऑफ दैट हैपेंस. ठीक है, बट वो सब यू विल रीड इन योर मेडिसिन. दैट्स नॉट रिक्वायर्ड एट दिस स्टेज. At this stage, I can tell you one thing: most common disease for which lung transplant is done, that is going to be COPD, chronic obstructive pulmonary disease, right? So it is the most common disease for which lung transplant is performed, and interstitial pulmonary fibrosis is the second most common disorder for which lung transplant is performed, right? So thank you so much guys for watching this video. We will be ending the session here. Please remember to hit the like button for this video, subscribe to the channel Let's Crack NEET PG, and share this video with your friends as much as possible. Do remember to drop a comment into this video when the video stops streaming. You can also go to my previous videos and drop a comment there. Okay, my Telegram channel, you guys all know, is t.me/Let's Crack NEET PG. Just go to this channel. The link is also there in the description. You can join from there. Okay, and do remember to hit the bell icon for notifications. My plus referral code is Chetanya10. You guys can use this referral code. Use this referral code in case you guys want to get a subscription. In case you guys want to get a subscription, we have a 34,000 plus MCQ question bank. We are running a limited time offer on the iconic subscription, right? Where we are giving the 92,000 rupees subscription for 60,000. This is for 60. The 2-year plan is for 50,000, and the 1-year plan is for 40,000. Okay, and for the plus subscription, we are running an offer that is 3 months plus 1 month. 3 months plus 1 month. So you can take the subscription, and one of the very good benefits that Unacademy gives you is that you can learn on a big screen. Okay, if you look at other applications, they are only restricting your learning to small screens. We allow access on laptops as well, so that is one advantage. Because आजकल ऑनलाइन लर्निंग इतनी ज़्यादा हो रही है, सो द मोर यू लर्न ऑन लैपटॉप्स द बेटर इट इज़, राइट? सो दैट इज़ वन कंसर्न, है ना? यू कैन ऑलवेज लिंक योर लैपटॉप टू योर स्मार्ट टीवी, राइट? और यू कैन ओपन, यू कैन यूज योर HDMI पोर्ट टू लिंक योर लैपटॉप टू योर टीवी, एंड यू कैन टेक एडवांटेज ऑफ दैट ऑल्सो. ठीक है, ठीक है. सो शुड वी एंड द सेशन? Now I want you guys to join me at 8 p.m. Very important session at 8 p.m. we have today. We have a session at 8 p.m. and that session is on the topic mucopolysaccharidosis type 1 Hurler disease. Okay, Hurler disease, right? So please remember to attend that session. It's going to be a very useful, very high yield session. So do attend, everyone. 8 p.m. I want to see you all, and the link I will also send on my Telegram channel so you guys can immediately join. Okay, chalo. So we'll bring this session to an end. We'll bring this session to a conclusion. Okay guys, bye bye, take care, have a nice time. Hi Aditya, see you at 8 p.m. If you have any doubts, you can ask me. Okay.